Hello, everyone. I'm Dr. Stephanie Chia. I'm a family medicine doctor that works at Penn Family Care at Hospital of University of Pennsylvania's Labor and Delivery Floor and Penn Presbyterian Hospital. Today, I will be discussing health disparities in COVID-19. This will be a brief look into the racial disparities and inequities of the pandemic, in illness, in death, and more recently with COVID vaccinations. This will be an exploration of structural racism and racism in medicine, which I hope will spark several topics for discussion. These are heavy topics that may hit closer to home for some of us, and for those in the audience who have experienced losses due to COVID, my heart is with you. Please take the time and space you may need. I have no disclosures. I would like to start this presentation with a few major statistics. In the United States, Latinx and Black residents have been 3 times as likely to be affected by COVID-19 as their white neighbors. 31% of Black residents know someone personally who died of COVID-19, and 1 in 3 Black residents have said they will not receive the vaccine. I want the audience to think about why this may be, to hold these statistics close as we walk through this talk. This has been a harrowing image for most of us. Coronavirus, the viral cause of COVID, an illness that is associated with fevers, cough, and difficulty breathing at the heart of this pandemic. From December 2019 to today, we've had a whirlwind of events, from the first note of concern from China to the first confirmed case of COVID in the United States in January. In the spring, the declaration of a pandemic and a national emergency, and after hundreds of thousands of lives lost in the United States, the recent emergency use authorization of the Pfizer and Moderna vaccines. During this timeline, there was also an evolution of the narrative of who was being most affected by the virus. In January, this was considered a rich person's disease, affecting only those with the ability to travel abroad. In the spring and summer, when we witnessed the death toll of folks young and old in our intensive care units climb with deaths from respiratory failure, the term great equalizer was used in the media to describe COVID. A line that was striking to me was this one: COVID-19 does not discriminate. I'm here to talk about why this statement is misleading and thus harmful. We learned quickly in Philadelphia that the virus was not affecting all communities equally. This figure showing across all age groups within the Black community that there were 2 to 3 times the number of cases per 10,000 residents in May 2020. Philadelphia is a predominantly Black city, with 44% of its residents being Black, so some might say that these numbers are biased. Looking at the national data from the American Public Media Lab, it corroborates this disparity, showing that even after adjusting for differences in age distribution between different races and ethnic groups, Black Americans have suffered more COVID-19 deaths of over 3.5 times that of white Americans. This figure also demonstrates that all minority populations have suffered more deaths than white counterparts. When looking at the statistics I presented at the beginning of the presentation here, too many have interpreted this increase in illness and death as a result of race, genetics, behavior that is voluntary, like not masking, not social distancing, due to choice or not taking this seriously enough. Well, in a national survey conducted by the Pew Research Center around the time of the declaration of a national emergency, it found that Black respondents are more than twice as likely as white respondents to view the coronavirus as a major threat to their own health. So here is a graphic from Harvard's blog of Science and Social Justice that lists a few potential explanations. Let us unpack these with some of the preconceptions mentioned earlier. Let us start with social distancing. A reminder that this is a privilege. Minority groups make up a majority of essential workers and are generally less able to work from home. The University of Pennsylvania health system, for example, in the environmental and cafeteria services, they are more than 75% Black, and more than half of the workers in patient transport are Black. Black and brown essential workers are more likely to live in multi-generational and multifamily households and live in densely populated areas. Just the simple concept of social distancing cannot be taken for granted. Next, to address pre-existing conditions. We know that there is a disproportionate rate of obesity, heart disease, high blood pressure, diabetes, and asthma in the Black community. When folks turn solely to genetics as the explanation, It is important to remember that race is a social construct, and there is more genetic diversity within the umbrella of one race than interracially. The disproportionate rate of illness in the Black community does not exist in a vacuum. Black and Brown communities are more likely to have less access to primary care, and in that, less access to testing, despite controlling for income, higher exposure to pollution. And a devastating part of this is the racial bias in medicine and what happens when Black Americans make it to that doctor's visit or make it to the hospital. A shameful demonstration of this racial bias was the experience and racist treatment of Dr. Susan Moore, a Black family medicine physician from Indiana, who died of COVID-19. Before her death, she was able to share with the public that her pain was underrated and undertreated. This story is mirrored by a well-cited study of medical students from the University of Virginia, where more than half of these medical students felt that Black patients experience pain differently, some attributing this to the thickness of Black skin. Most of this is aptly summarized with a quote by Patricia Peck, a writer for the New York Times and the Atlantic. The virus has exposed and targeted all of the disparities that come along with being Black in America. All of those separate bubbles signal to cycles of poverty, job and housing insecurity, food inequities, cycles and patterns that are no accident and are the product of systems of redlining, gentrification, housing discrimination, forms of structural and systemic racism. It is clear that these disparities have existed prior and are not unique to COVID. They've just been highlighted by the pandemic. In my practice at Penn Family Care, we serve a predominantly Black patient population in West Philadelphia. I've heard numerous stories from folks who work for the Postal Service, grocery stores, healthcare workers, sanitation workers. The story that is most salient to me right now is from a woman I met about 2 weeks ago now in the clinic. When I asked her if it would be okay for me to share her story with you all, she really hoped that you would listen and be interested. She's a Black woman in her late 50s, born and raised in Philadelphia. She works in patient transport at one of our hospitals. She lost her husband to COVID-19 in December 2020. Her partner had kidney failure secondary to multiple health conditions and had limited access to health care throughout his life. He was on dialysis and had recently received a kidney transplant, so was on immunosuppressive therapy. She was not able to work from home as she was an essential worker. When she did return home, she was not able to socially distance from her partner. She lives in a multi-generational home and spoke fondly during our visit of her grandkids and her children. Themes that came up during our visit were questions of guilt, grief, and blame. She also shared that the reason she continues to get up and go to work each day and brave passing by the floor in the hospital where he died is making sure that the patients she transports have company and don't feel alone during their isolation in the hospital. In tandem with hearing these stories of resilience from the community that we serve, one of the most common inquiries we have been having in the office is about the vaccine, many asking when it can be their turn to be vaccinated. In order to create our current systems of distribution and vaccine planning, the CDC provided a guideline that prioritizes two major tenets: the prevention of morbidity and mortality, illness and death, and the preservation of societal functioning. Each state is able to perform their interpretation of these guidelines with their own priorities. We are most familiar with 1A in the vaccination of healthcare workers and long-term care facility folks. In certain states like Nevada, law enforcement is in this initial tier. In others like Massachusetts, folks experiencing homelessness or incarceration are in 1A. Outlined here are the priority groups by age and occupation in 1B and 1C. With the current trajectory, some project that by summer, young, healthy folks will have access to the vaccine, and herd immunity may be achieved by winter if more than 75% of the general population has been vaccinated. And since the vaccine rollout, there has been a change in America's interest in this limited resource. Since September, vaccine hesitancy has decreased across the board, with this taken from the Kaiser Family Foundation, showing that if it were determined to be safe by scientists and available for free for everyone who wanted it, this figure shows the percentage of respondents that would definitely, probably get the vaccine, the dark blue line, or definitely, probably not get the vaccine, the light blue line. You can see here that there has been a general trend of increased willingness and decreased hesitancy between September and December. Notable is a sizable percentage of Black respondents who continue to report that they would not receive the vaccine, compared to other major racial and ethnic groups. When reviewing the top 5 most vaccine hesitant groups, these included Republicans, middle-aged folks, rural residents, Black adults, and essential workers. When reviewing the reasons why folks are vaccine hesitant, when focusing on Black respondents' concerns, the most prevalent are concerns about side effects, the same main concern among other vaccine hesitant groups. Black vaccine hesitant respondents also reported wanting to wait to see how the vaccine treats other people, and also concern for getting COVID from the vaccine. Notably, when reviewing the statement, the risks of COVID-19 are being exaggerated, this was not as much of a concern for Black vaccine hesitant respondents compared to the other groups. In my eyes, these responses reflect concern of COVID-19 and the impact of the vaccine. Some historic background may provide some context for this concern. We know that the medical system has failed to earn or deserve the trust of Black, Indigenous, and other communities of color. With more infamous instances of the Tuskegee experiments in the 1930s, where researchers knowingly did not treat Black men with latent syphilis, to more locally, Albert Kligman, a dermatologist who was part of Penn faculty up until his death in 2009. Kligman exposed residents of Holmesburg Prison, formerly in Northeast Philadelphia, to high doses of dioxin, a contaminant responsible for Agent Orange's toxicity. This was a chemical used in the Vietnam War as a herbicide. It was also associated with development of leukemia, lymphoma, and birth defects. He also intentionally exposed incarcerated persons to infectious pathogens like herpes and staph. Given the racist nature of the prison industrial complex then and now, most folks at Holmesburg Prison were Black. Even more proximal to this audience, Penn undergraduate students, is the relationship between UPenn and the neighborhood Black Bottom. After World War II, there was an area in West Philadelphia known as Black Bottom, a thriving, predominantly Black community filled with Black-owned businesses. In the late 1950s, UPenn, Drexel, and University of the Sciences experienced an uptick in their enrollment and sought to expand their campuses. Thus, there was a push to rename and rebrand the area as University City. These universities joined with Presbyterian Hospital to form the West Philadelphia Corporation, and the corporation bought up property from landlords, boarded them up, or demolished them. These practices creating a blight where there was once prosperity. By declaring portions of the area blighted, the city was able to acquire these private properties, and by 1970, the West Philadelphia Corporation managed to displace around 5,000 residents, destroying a whole neighborhood full of homes in order to make way for their vision of University City. Knowing this, let us return to the question of medical mistrust and medical systems' failure to earn that trust of the community. Here is an image of Sandra Lindsay, the first person to be vaccinated in the United States, a Jamaica-born nurse from Queens, New York. I want us to take a moment to think about what this image means to you, and what is your reaction to this image. Now that the vaccine has had a few weeks in distribution, since Sandra Lindsay, who is getting the vaccine? Perhaps to many like myself, it comes as no surprise that by far the most vaccinated racial group are white residents. The figure on the left is data from the US Census Bureau, specifically about Philadelphia, which shows a disproportionate rate of vaccination compared to the percent population for white Philadelphians and a grossly inverse relationship for Black Philadelphians. In a recent article published by CNN, Pennsylvania has distinguished itself with this figure on the right as having one of the most striking disparities, with white people getting vaccinated at 4 times the rate of Black people, even after adjusting for differences in population. At Penn, there's been a 40% difference in uptake of the vaccine between white and non-white Penn employees that qualify for Phase 1A. This is not unique to Philadelphia. At a vaccination site set in Washington Heights in New York City, a predominantly Latinx neighborhood hit hard by the pandemic, the initial rollout for people aged 65 or older noted that the primary beneficiaries were white folks traveling from all over the city and state. In an article published by the New York Times just a few days ago, in Washington, D.C., wealthier, largely white neighborhoods have been overwhelming vaccination appointment systems and taking a disproportionate share of the limited resources. When trying to course correct by reserving these vaccines for those in the most hard-hit zip codes, the clinic sites were met with outcry from the wealthier wards, frustrated that shots had been reserved for certain or impoverished sectors of the city, that this was not fair, and that they were being punished for being computer savvy. So when it comes to further analyzing vaccine planning, many of us strongly feel that there must be more than the two tenets previously presented. A third tenet of vaccine ethics must be incorporated to address the racial inequities during this pandemic. Not a new or novel concept, but this brings us to the distinction between equality versus equity. Although both concepts promote fairness, equality attempts to achieve this through treating everyone the same regardless of need, while equity achieves this through treating people differently dependent on need. We know who has suffered the most and which communities have lost the most lives respectively. Thus, by extension, we can surmise who would have the most to benefit and the most to gain from receiving the vaccine but are not receiving it. There is real vaccine hesitancy, however, instead of falling yet again into the pitfall of just ascribing disparity to choice and behavior, let us learn from the disparities in COVID-19, illness, and death when approaching the disparities in COVID-19 vaccination rates. Let us look at the potential barriers that are in place that are systemic and structural. In the case of New York City, the free-for-all, equal access meant primarily English-speaking white persons with the means to travel all over the city and state with computer and internet access were the ones signing up for those slots. In the case of Philadelphia, where the average life expectancy for Black persons is 73, and the average life expectancy for Black men is 69, and for white persons is 78, Phase 1B planning with a 75-year-old age cutoff is problematic. Thus, when looking at the phases of vaccination for Philadelphia, for Pennsylvania, for the rest of the country, many are pushing for the incorporation of consideration of racial differences in illness and access with varying success. There is a call for not only tailoring the phases, but tailoring the setting of vaccination sites and the methods being used for outreach and retention. This can be done much like in DC by creating systems to offer expedited access to the people in the neighborhoods who've been the most affected by the pandemic and adhering to it, instead of asking the community to come to the medical system to go to the community, to have facilities that support folks with other primary languages, and investing and really investing in community liaison outreach and patient support to ensure that those who want the vaccine and are at highest risk are the ones who receive it. A critical eye must be used towards the guidelines and adapt them appropriately to the community and who they will most impact. To address these disparities, we must look again to the systems and dismantle where we find its bias and its structural racism. Rewrite the current patterns of operation and thought to achieve not an equal but an equitable process. Thank you for your attention. As you are home and thinking about this talk, I really want to address and highlight a previously proposed discussion question for the Salon. How will the distrust of vaccines in communities of color due to the medical system's historic dehumanization of BIPOC affect equitable allocation of vaccines? How can we work to gain this trust back? I want to address how important the wording of this question is, and that by using its first clause and by distinguishing a we in the second, this question can be othering. And by othering, it signals that the Black community and other communities of color affected by the pandemic are not part of this conversation and are not a part of creating and envisioning potential solutions. It also assumes that the medical system deserves this trust now and removes agency from the communities that may not want a part in establishing this trust. Just some additional food for thought. Thank you all again for your attention and your interest in this topic.